a randomized trial comparing multiband mucosectomy and cap-assisted endoscopic resection for endoscopic piecemeal resection of early squamous neoplasia of the esophagus. Introduction. Endoscopic resection is the treatment of choice for early esophageal squamous cell neoplasia that is confined to the mucosa, such as high-grade intraepithelial neoplasia, HGIN, and the early stages of esophageal squamous cell carcinoma, ESCC. ESCC is the sixth most common cause of cancer-related death worldwide and has a particularly high incidence in certain high-risk areas, such as Central Asia, East Africa, Iran, and China. Nearly half of the worldwide ESCC cases occur in China, where ESCC is the fourth leading cause of cancer-related death. ESCC reaches a remarkable incidence of 1 in 1,000 in certain densely populated areas comprising over 100 million people. ESCC is usually diagnosed at a late stage and has a poor prognosis because of the relatively thin esophageal wall and rich lymphatic network, which contributes to metastatic spread of the disease at an early stage. The chance of lymph node metastasis depends on the penetration depth and the differentiation of the lesion. Timely detection of the early stages of ESCC, when the lesion is still confined to the superficial mucosal layer, is of obvious clinical importance. In high-incidence areas of China, high-volume screening programs are currently being conducted, in which over 150,000 subjects per year undergo endoscopy with Lugol dye staining. Areas that are suspicious for neoplasia will appear as unstained lesions, USLs, in the brown iodine-stained normal squamous esophagus. In approximately 5% of the screened subjects in China, endoscopic therapy is warranted, yet limited endoscopic expertise and resources are available. For the adequate execution of esophageal screening programs in these high-risk areas, a low-complexity, low-cost treatment modality would have many advantages. The most widely used technique for endoscopic resection of early squamous cell neoplasia in the esophagus is the endoscopic resection cap technique. With this technique, lesions up to 2 centimeters in diameter can be removed en bloc, while larger lesions require removal in multiple pieces, piecemeal resection. The endoscopic resection cap procedure is, however, technically demanding, especially during piecemeal resections, where submucosal lifting and positioning of a new electrosurgical snare in the cap are required for every separate resection. An alternative endoscopic resection technique is the multiband mucosectomy, MBM technique, using a modified variceal band ligator. MBM does not require submucosal lifting, and positioning of the snare, which can be used for all resections, is much easier. Previous studies in Barrett's esophagus have shown that MBM is safe and effective for removal of mucosal neoplasia, with shorter procedure times and lower costs compared with the endoscopic resection cap. A recent feasibility study on the use of MBM for esophageal squamous neoplasia, performed in a tertiary care unit in China, suggested that MBM is safe, effective, fast, and has a durable treatment effect. Zhang et al. Therefore hypothesized that MBM may have significant advantages over the endoscopic resection cap technique, especially in countries where endoscopic expertise and resources are limited. The aim of this study was to prospectively compare MBM against the endoscopic resection cap for piecemeal endoscopic resection of early mucosal squamous cell neoplasia of the esophagus, assessing the effectiveness, safety, and durability of their treatment effects. The secondary purpose of this study was to investigate the ease of application and costs of these techniques, which may be of practical importance for the implementation of high-volume screening programs in areas with a high risk of esophageal squamous neoplasia. Background and study aim: piecemeal endoscopic resection for esophageal high-grade intraepithelial neoplasia, HGIN, or early squamous cell carcinoma, ESCC, is usually performed by cap-assisted endoscopic resection. This requires submucosal lifting and multiple snares. Multiband mucosectomy, MBM, uses a modified variceal band ligator without submucosal lifting. In high-risk areas where ESCC is common and endoscopic expertise is limited, MBM may be a better technique. The authors aim to compare MBM to the cap-assisted technique for piecemeal endoscopic resection of esophageal ESCCs. Methods. Patients with mucosal HGIN ESCC, 2 to 6 centimeters, maximum 2/3 of esophageal circumference, were included. Lesions delineated by 1.25% Lugol staining were randomized to MBM or cap-assisted piecemeal resection. Endpoints were procedure time and costs, complete endoscopic resection, adverse events, and absence of HGIN ESCC at 3-month and 12-month follow-up. Results. Endoscopic resection was performed in 84 patients, 59 men, mean age 60, using MBM, N = 42, or the endoscopic resection cap, N = 42. There were no differences in baseline characteristics. Endoscopic complete resection was achieved in all lesions. Procedure time was significantly shorter with MBM, 11 versus 22 minutes, p less than 0.0001. One perforation seen after using the endoscopic resection cap was treated conservatively. Total costs of disposables were lower for MBM, €200 versus €251, p = 0.04. At 3-month and 12-month follow-ups, none of the patients had HGIN ESCC at the resection site. Conclusion. Piecemeal endoscopic resection of esophageal ESCC with MBM is faster and cheaper than with the endoscopic resection cap. Both techniques are highly effective and safe. MBM may have significant advantages over the endoscopic resection cap technique, especially in countries where ESCC is extremely common but limited endoscopic expertise and resources exist.